Hello everyone. Let us continue with the NEET SS General Surgery lecture series. So today we are going to cover a very important topic. A lot of MCQs can be asked from those topics. So just the high yielding points from those chapter. So let us start with the discussion on shock. And the first thing that we are going to study is the lethal triad. So most of us already know about this lethal triad. It will be a very easy question if you get what are the components of the lethal triad. So we already know about the components of the lethal triad, that is acidosis, hypothermia, and coagulopathy. So these components are very easy to remember. Why there is acidosis? Because of the inadequate tissue perfusion, there is lactic acidosis. Because of the anaerobic respiration, and because of this the ATP produced is also less. So because of the less ATP, the heat generation is also less, so there is hypothermia. And because of hypothermia and the acidosis, the coagulation factors cannot function properly, so there is coagulopathy at the same time. So this is the vicious cycle of the shock known as the lethal triad. And definitely the questions won't be what are the components of the lethal triad. This easy question won't be asked. The questions will be on each component. Now let us see the MCQs which can be asked from each of these components. First, we will come to the acidosis, and regarding acidosis, there is a very important topic of discussion, that is THAM, and this is a molecule which is very important for correction of the acidosis that is being used. Why it is important? What are the advantages of using THAM, which stands for tromethamine trace aminomethane? What is the advantage of using this over sodium bicarbonate? Because there is less generation of carbon dioxide. Since it does not generate carbon dioxide, therefore we can use it in a closed system. That means we do not require a respiratory system to exhale the carbon dioxide, so we can use this in a closed system. So very important. It's mentioned in the Savistton that we can use this in the closed or semi-closed system, unlike the sodium bicarbonate, which has to be used in a open system only. Now, second important thing about it is it rapidly distributes in the extracellular space and slowly into the intracellular space, and it is excreted by the kidneys. So these are the important points which can be asked about this molecule. So it is better than sodium bicarbonate both as a buffer and as compared to the side effects. But what side effect you have to keep in mind when we talk about this molecule? We have to know that this THAM molecule, which is used to correct the acidosis, this can lead to respiratory depression. Why respiratory depression? Again, try to think, this molecule does not produce carbon dioxide. Since carbon dioxide is required to stimulate the respiratory drive, since this carbon dioxide is not produced in this molecule, so therefore there is chances of respiratory depression. So we have to know these important salient features about this molecule. Again, the exam format we know can be one-liners, and it's a mixture of the application of this knowledge. So there is a very important concept about it. Suppose they give you an ABG picture like this. They give you an ABG picture which is suggestive of a acidosis. Definitely the pH is 7.2 and the PCO2 is 25 and the bicarbonate is 10. That means we know the best deficit is 16. So if you have to decide how much molecule of THAM to be given to this patient, they might give you an ABG and they might tell you that this is a 60 kg gentleman with a base deficit of 16. If you know this ABG picture and you are been asked to give the THAM dose to this patient, then what is the amount of THAM dose that you will be giving to the patient? So that will be calculated by this formula, and this is a very important formula, that is body weight into best deficit in millimoles. See, it's given in millimoles only. So what you have to do is, if you get a 60 kg male patient with a best deficit of 16, then it will be simply 60 into 16. That's how you decide how much molecules of THAM, how much millimoles of THAM you have to give in this patient. So this is a very important topic of discussion. I have a feeling that this might be asked as an MCQ in the upcoming exam. So as far as acidosis is concerned, just try to remember about this. The basic concept about the pathogenesis of acidosis we already know is because of the anaerobic respiration. Now, if we move to the second component, what was the second component? Was the hypothermia. See, again, hypothermia, there is very few important MCQ points, and all the sentences which are, you can see in the slide, all of them are MCQs. So regarding hypothermia, what they're going to ask you is, what is the most important way to correct hypothermia? If the patient is in a hypovolemic shock, as in or in hemorrhagic shock, the most important way is to control bleeding. That is the first and the most important thing to correct hypothermia. But if they ask you what is the best method to control, what is the best method to correct hypothermia, that is active internal warming. And there are various methods of active internal warming. The maximum warming that can be produced to a patient is by a cardiopulmonary bypass, and the minimum internal warming is produced by the airway through the mechanical ventilation. So this is a table which is given in Saviston, and believe me, this can be asked in the exam, like which is the maximum warming producing method, and which is the maximum, that is the cardiopulmonary bypass, and which produces minimum warming. So we can see from the heat generated in the form of kilocalorie per hour, that's how we can correct hypothermia. There are various methods of correction, but from the MCQ point of view, we have to keep these points in our mind. Let us move ahead to the third component, and which is also very important, that is the coagulopathy. See, in coagulopathy, whenever we discuss about coagulopathy, always remember this question can be asked in the exam. What is thromboelastography? So thromboelastography is basically a dynamic measure of coagulation. This is mentioned in the Saviston. It totally describes the thromboelastography in detail. But Bailey and Love very typically gives this diagram, and this diagram taken from Bailey and Love is very potential to be asked in the MCQ. They can pick up any of this image and ask you, what does this represent? So let us try to understand this thromboelastography in slight detail. See, there are three important things we have to understand. The first is this perpendicular line. If we think that A represents a normal thromboelastography representation, what do? We take a sample of blood, we make a smear of it, a kind of smear, and we see the pattern that we get, and that represents presence or absence of coagulopathy. The first thing is this black line that we can see, and this represents the latent time. And what does latent time means? The latent time basically means the time taken to start the fibrin formation. The second important thing is this angle. This is known as the alpha angle, and this basically represents the rate of fibrin formation. And the third important thing we have to know is this thickness, which is known as the strength of the fibrin which is formed. The first image being the normal thromboelastographic representation. What does it indicate? That after certain latent time, there is starting of the formation of the fibrin with an adequate rate, and the strength remains the same for the rest of the time. Now what happens? Let us compare the images. Let us compare the latent time. So if the latent time is very much decreased, as in we can see in the last image, that is the E. So if the latent time is decreased, that means the time to form the fibrin is very less. That would indicate a hypercoagulable state. So it's a very simple MCQ. If they give you this image, so they might ask you, what does this image represent? So this might indicate that the patient is in a hypercoagulable state because the latent time to form the fibrin is very less. The second thing they can ask you is about the image number B. In the image number B, we can see that the latent time is the maximum. So when the latent time is at the maximum, that would indicate that the time to form the clot is delayed. That means that would indicate that the patient is having a delayed clot formation. So there might be many reasons for it, but you know that the patient is in a delayed clot formation stage because the latent time is maximum. So that's how you can understand, depending on the latent time, whether the patient is in a hypercoagulable state or patient is having a delayed clot formation. The next thing is about the rate of clot formation. See, the rate of clot formation is represented by this angle. The next we come to the very important point, that is the strength of the clot formation. See, the strength of the clot formation is represented by this thickness. What we can see in the C image is that the thickness of this figure is less. So the strength of the clot that is formed is less. And what we can understand from the fourth image is that the clot that is formed is undergoing breakdown, is undergoing lysis. So this is a lytic stage. So this is very, very important for us to know this thromboelastography. This is not routinely done, but this has been recommended to be used in patients with trauma, in patients with liver transplantation. This is recommended because this gives you dynamic measurement of the coagulation parameters. What a dynamic measure means, if you get a coagulation profile like an INR, PT, P time, they all give you the static figure of the coagulation profile at that moment of time. But if you need it over a period of time, then you do a thromboelastography to get the dynamic measure of this coagulation. I feel like any of this figure might be picked up in the MCQ, and we should be prepared since it's given in Bailey and Love. Every image in Bailey and Love is an exam question. So try to know the basic concept behind this, and they might ask you this question from this image. So next is acute traumatic coagulopathy. See, this is also a very important entity which has been mentioned in Bailey and Love, and it's very simple to understand. Like trauma is a cause of shock. Because of the hypovolemic shock, the patient is going to coagulopathy, and we already know this is a component of the lethal triad. So why do we have to know this? Because of the mortality. See, this is mentioned clearly in Berry and Love that this patients, 25% of the trauma patients will develop this acute traumatic coagulopathy within minutes of injury, and it is associated with four-fold increase in the mortality. So this entire sentence is an MCQ. So there is a 4 times increase in the mortality, and 1/4 of the patients will undergo this, and there is 4 times increased mortality. So just remember this figure, which can be put up as an MCQ, acute traumatic coagulopathy. We already know the pathogenesis behind this. Now see, when we talk about the traumatic coagulopathy, we should also know how to deal with them. A patient has come with a polytrauma or whatever be the cause, patient is in a hypovolemic or a hemorrhagic shock. Now what we have to start immediately, we should think about the damage control resuscitation, and this brings up to the concept of DCR. Now see, there are various components of DCR that has to be very clear from MCQ point of view. The first thing is about this acute traumatic coagulopathy. This is very important. The first component being the correct the coagulopathy. And how do we correct this coagulopathy? We're going to come to this over time. But the first thing is you have to understand that we have to allow permissive hypotension. That means we have to do the resuscitation, keeping the blood pressure not too high, not too low, up to an optimum level so that the patient does not start bleeding more. And next thing what we have to understand is we have to avoid using excess of crystalloid and colloid infusion. So what is recommended? This damage control resuscitation encourages early use of the blood products. We use the blood products, that is the packed red blood cells, platelets, FFP. It is recommended to be used as early as possible. As soon as you are able to correct the bleeding, you start with the blood products. Don't use the fluids because that will lead to dilutional coagulopathy, and shift the patient for surgery. That is the last strategy of the damage control resuscitation. Now, there is a very important thing that most of the candidates try to overlook. It's written in Bailey and Love very clearly that we are correcting the coagulopathy. We are providing the patient with a blood products. Okay. Now, the blood product that is recommended in trauma, we already know it's 1:1:1 strategy. We use the 1:1:1 balanced transfusion protocol. And what do we use? One PRBC, one FFP, and one platelet. What we have to understand is the Bailey and Love clearly mentions that this balanced transfusion approach cannot correct the coagulopathy. We have to be very clear about it. This does not correct the coagulopathy. So what does this sentence mean? Taken from Bailey and Love, it clearly says that the coagulopathy should be treated in addition to the administration of the 1:1:1 blood transfusions. So if you think that you are providing this blood transfusion and that is enough, FFP and platelets are enough for the coagulopathy correction, no, it's not that. And that's why there came the concept of using tranexamic acid in patients with trauma. And again, this is a very important MCQ. When to use this, why to use this, we already know, because if you are following the damage control resuscitation, even then we have to use tranexamic acid because the DCR, the blood products cannot correct the coagulopathy. So you have to use an antifibrinolytic, that is the tranexamic acid. And what you have to remember, the number of 110, that's a very, very significant number when it comes to tranexamic acid. So what is this 110 mantra? The first thing is we use 1 gram of tranexamic acid over 10 minutes. The second thing, it is to be used in patients with a pulse rate of 110 per minute and with a systolic blood pressure of less than 110 millimeter of mercury. So this is very important. The rule of 110. There are three important things: 1 gram over 10 minutes, pulse rate more than 110, systolic blood pressure less than 110. The next thing is it has to be given within 3 hours of injury. That is very, very important. Regarding the coagulopathy component, these questions can be asked in the form of MCQs, in the form of conceptual long questions. They can ask you in any way. So wherever they try to trap you, you can come out of this if you know the basic concept. And all this, whatever I'm telling you, are from Bailey and Love. Let us try to move ahead. Now let us move into the very basics of the clinical features of shock. Now, the clinical features of shock. This table looks simple, but there can be few MCQs which most of you already know. We'll just try to highlight a few MCQs that can be asked from this table. See, they might ask you, the first thing is, when does the pulse rate and the respiratory rate start to increase? So if you compare this to the hemorrhagic shock, then this will be grade 1, 2, 3, and 4 hemorrhagic shock. Similarly, in Berry and Love, they mention as compensated, mild, moderate, and severe shock. So whatever be it, the MCQs might be framed, the options might be framed in both the ways. If they ask you respiratory rate is increased in which stage, always remember it's the mild or the grade 2 of the shock, or the class 2 hemorrhagic shock. If they ask you when does the tachycardia start, so it's the class 2 shock. When does the hypotension start? It's in the class 3 shock. And also, when does the urine output starts to decrease? It's the class 3 shock. So these four questions can be asked in this. The rest, any point might be picked up as a question, that is labored breathing is seen in. Labored breathing is seen in severe shock. So anything might be picked up as an MCQ, but the highlighted, the circle things are very commonly asked. This is a last minute revision table to be kept in mind. Now, try to solve this question. This is a very important thing. When we solve this answer, you'll understand that there's a table in Bailey law which clearly mentions about this. Like for assessing the gut perfusion, which can be used except, all of the following can be used except. So what can we use, what we cannot use? So just remember, we usually use one of these three, but we don't use this near infrared spectroscopy. This is a very important point. So if you look at this table taken from Bailey and Love, this is very, very important. Anything can be picked up as an MCQ again from this high yielding table. For the gut perfusion, as we saw in the question, that this is a straightforward question from Bailey and Love, nothing to explain much. What you have to understand is the systemic perfusion is basically determined from this best deficit lactate and the mixed venous oxygen saturation. And we are going to talk about them in the next few moments. Now try to understand. Anything can be picked up as an MCQ. So mark this as a last minute revision. You have to go through this table. This is very high yielding table. Now, regarding the mixed venous oxygen saturation, there can be a few questions that you have to keep in mind. See, the mixed venous oxygen saturation, basically the concentration of oxygen in the venous blood. Normally, it is about 50 to 70%. Now, when do we expect a less than 50% oxygen saturation in the venous blood? When the oxygen delivery to the tissues is less. If the oxygen delivery to the tissues is less, that is in most of the type of the shock, hypovolemic, cardiogenic, or distributive shock, we get this less than 50% of the mixed venous oxygen saturation. But when do we get more than 70% of this? When do we get that the oxygen saturation is more? When the delivery to the oxygen is normal. But what happens? The utilization of the oxygen is less, which happens in the distributive type of shock, that is the septic shock. So in septic shock, we get more than 70% of the mixed venous oxygen saturation. Now, how do we measure them? We take the blood sample from a catheter which has been placed in the right atrium of the heart. Tip of the catheter has to be placed in the right atrium of the heart. This is very important. Now, if you don't place the tip of the catheter in the right atrium of the heart and you place it slightly above and you take the sample from the superior vena cava, then you can get a higher value of the mixed venous oxygen saturation. Now, why do we get a higher value? This is a line straightforward taken from the Bailey and Love, which clearly says that the oxygen extraction is more from the tissues in the lower extremities. So if you take a blood which is mixed venous blood of the right atrium, so the saturation will be less in the right atrium compared to the superior vena cava. So this is a very important point that can be asked in the exam regarding the mixed venous oxygen saturation. Again, moving on to another high yielding table from Bailey and Love. So this we have to understand. It's not that difficult. It might look so, but it's not difficult. Try to understand the cardiac output will definitely be low in hypovolemic shock because the volume is less. In cardiogenic shock, the heart is not pumping, and obstructive shock, the heart is unable to pump because of the pressure from outside, as in constrictive pericarditis. Or in distributive shock, the cardiac output will be higher because the volume is normal and there is no cardiac pathology. So the cardiac output will be high to compensate for the decreased perfusion to the peripheries. So we have to remember this first thing is very simple. Next, we talk about the vascular resistance. The vascular resistance, see, there is vasodilatation in the septic shock. The extremities is only exception, that in septic shock or in distributive shocks, we get that the periphery extremities are warm and there is vasodilatation. So the vascular resistance is low in these patients. Regarding the venous pressure, The venous pressure will definitely be low because overall there is vasodilatation in septic shock. So even the arterial as well as the venous pressure will be low. But why is it low in case of hypovolemic shock? It is low in case of hypovolemic shock because the volume of the blood is also low. So anything might be picked up as an MCQ. So if you know the basics, you can mark any of the answers correctly. So don't fall and try to keep yourself very clear. Regarding the last 2 points we already discussed, it's more than 70% in case of distributive or septic shock, and it's less in all other types of shock. Base deficit is high in all the types of shock. You have diagnosed the patient with the shock. Now comes the important thing is resuscitation. Again, Bailey and Love gives this table of the type of the fluids, different types of the fluids and their composition. So you might get a question from this table also. The different fluids. So what MCQ can be framed from them is they might ask you which of these fluids contain the maximum amount of the potassium. So that is a gelaffusion. But if they ask you which of the crystalloid contain the maximum amount of potassium, then comes the dextrosaline. So always try to remember the question can be on crystalloid or colloid or overall fluid which contains the maximum amount of potassium. So overall, jelly fusion has the maximum amount of potassium, but if they ask is specific of the crystalloid, then it is a 5% dextrose or 4% dextrose. Now, potassium containing fluid is, apart from this, is Hartmann solution, which is more towards the physiological level. But when it comes to they might ask you which is a physiological fluid, whether it's normal saline or whether it's Hartmann solution. And the third option might be plasma light. So plasma light resembles the plasma most accurately compared to the Hartmann's or the normal saline. So if you get a plasma light in the option, mark it as a plasma light. That is the composition of which fluid is very close to the plasma level, then it is a plasma light. The Hartmann solution, the sodium level is slightly less, so it's slightly hypotonic, whereas normal saline is sodium is more, so it's slightly hypertonic. So this is very important. Try to remember this. Anything can be asked from here, but it's very simple. There are few markers of resuscitation. Among them, one of the very important marker is venous lactate, and this table taken from Bailey and Love is very important because this is going to be asked in the exam. Any MCQ might be picked up from here, like if the lactate level is less than 2 millimole, what do we do? 2 to 3, what do we do? More than 3 millimole, what is to be done? And more than 5, what has to be done? So the easy way to remember this is European Trade Union Department. E stands for early total care if the lactate is less than 2. Trade, T stands for the follow the trend. Whether look at the trend, just wait and watch. And if it is more than 3, you have to think that the patient is under resuscitated, so you continue with the resuscitation. And what is D? If it is more than 5, then you take the patient for surgery. That is European Trade Union Department. If you know this mnemonic, try to remember. If you get a value of lactate, so what step has to be done? That can be an MCQ. So we have done with the resuscitation. So these are the various high yielding topics from the Bailey and Love as well as from Sabiston. We have tried to summarize in shock. We don't have much time to spend before exam. So I'm trying to summarize as much as possible within 10 minutes or 15 minutes so that all the high yielding topics you have them in your quick access before the exam. Now the next few things from shorts, which is very importantly asked in NB, I have seen in the previous papers. So few things we have to know, few mantras that we have to know regarding the electrolytes. Now regarding electrolyte, they might ask you regarding hypernatremia. How do we correct hypernatremia? So the first important formula, they might ask you, formulas can be there in the exam. So always try to remember that they might ask you about the correction formula for hypernatremia, which is not common. Hyponatremia is very common, but uncommon things can be a possibility of being asked. So water deficit, you calculate the water deficit, and that's the amount of water that you have to replenish to correct the hypernatremia. So water deficit is the serum sodium minus 140 by 140 into total body weight. So this is very important correction of hypernatremia formula. Next, there is another important thing that you have to know about the hyponatremia is that there is some decrease in the sodium concentration when the plasma glucose level is high. And this is mentioned in shorts, and I feel that there is a possibility of being asked in the exam, what is the relation of the plasma glucose and the sodium level. So always remember, for every 100 milligram per dl increase in the glucose, so if there is a diabetic patient with glucose of 300, so for every 100 increase in the plasma glucose above the normal, the plasma sodium will drop by 1.6 milli equivalent per liter. And this is a very high yielding topic, I feel, that can be asked. Next similar thing is about the potassium also and the relation with the pH. Now always try to remember that the change in the potassium associated with the alkalosis can be calculated by this formula. So potassium decreases by zero point 0.3 milli equivalent per liter for every 0.1 increase in the pH above normal. So this is also very important statement, straightforwardly taken from the shorts. So this will be a very important edge to you over the others if you know these values, if you know this one liners. If you're lucky, you get the one liners, and then definitely you can expect questions from these topics. So with the increase in the pH by zero point 0.9, the potassium will decrease by 0.3 milliequivalent per liter. Don't have to know the details of it, just know the basic values so that you might get a numerical question. Now, there is another very important thing simultaneously you have to understand, that if the patient has a associated hypomagnesemia along with hypokalemia, you cannot expect to correct the potassium level without correcting the magnesium level. So in those patients, the magnesium level has to be corrected first. And who are those patients who are likely to develop magnesium depletion? Mainly patients with the drug intake such as amphotericin B, aminoglycosides, cisplatin, and ifosfamide. They have this magnesium depletion. So guys, what I am trying to do is summarize the few important topics from the chapter on shock, which you already know. It's 2 months before exam. You are not going to have much time for the preparation. You are revising the whole day. So what my purpose will be to pick a few points from the, pick a few one liners or pick a few concepts from the chapters that you have already read, try to hammer them into your brain so that you don't forget them before the exam. So this is just a quick way of revising the chapters so that we can overcome from the shock that the NB has given us with the change formats, and we are very quickly able to adapt it. As soon as you are able to adapt, you will be able to perform very well. So try to keep solving the questions, try to follow these notes, very few slides and very short lectures. I hope you find this useful. So stay tuned. I'll upload more videos on the upcoming chapters on general surgery. So till then, keep preparing, keep studying.